Good afternoon and welcome to HealthSystemCIO.com's All-Star Panel, Garbage In, Garbage Out, Exploring Data Governance Approaches That Work, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Collibra. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view it in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel for you to send in questions, enter them in the Q&A panel, the lower right-hand corner of your screen, and submit them at any time. Leave the default set to all panelists, and we'll look at those later in the program. We're also going to have a couple of polls out there today for our audience, so the polling panel will automatically open when we launch, and we'd love for you to participate in those. And you can download the deck using the URL on your screen that's been sent out in the chat box, and it's also at the bottom of some of our slides. Just so you see how we're going to spend our time today, we're going to go overall about 45 to 50 minutes. First, we're going to have our panel discussion featuring Kirk Hanson, Director of Enterprise Data Governance with Geisinger Health System, Tom Hammergren, Corporate Director, Data and Integration Solutions with TriHealth, and Chris Cooper, Healthcare Sales and Strategy Leader with Collibra. So without further delay, we are going to jump right into our panel discussion. Kirk, let's start off with you. Do you want to give us an overview of Geisinger?
Sure. We're an integrated healthcare organization. We have a clinical side and a payer side. It gives us some tremendous advantages in terms of what we can do with our data. Of course, it also introduces a number of fairly significant challenges, and data governance is right in the middle of resolving all of those.
Okay, excellent. Very good. Tom, a little bit about TriHealth.
Yeah, TriHealth serves really the southwest region in Ohio, so we pull in some people from Indiana and northern Kentucky. We're a clinically integrated network that really was forged based on two acute care hospitals, Bethesda and Good Samaritan, coming together with a joint relationship to create TriHealth, and it's since '95 expanded to include over 140 care sites that spans from primary care through education, preventative social programs, as well as all the service line and hospital services that people would come to expect.
Excellent. Chris, Collibra?
Yeah, thanks, Anthony. Collibra is a data governance software vendor. We provide a platform for helping organizations bring together the people, the process, the technology, the metadata needed to enable and sustain enterprise data governance programs. Really, in summary, we help organizations make sure that their employees can find the information they need, understand what it means, and then trust that that information is the right decision and being used in the right ways to make their decisions.
Excellent. Very good. All right, let's get into the meat of our discussion. Tom, let me start with you. What are the main reasons for poor data quality?
I could jokingly say it's one thing called humans, but it's probably more than that. So I think there's really, if we look at it from an internal perspective, there's quite a few reasons for this. I think there's a lot of moving parts in healthcare, obviously, including, I think, when people originally started out, the hospital and ambulatory side were clearly separated, running under separate systems. So as we've sort of evolved and tried to bring those things together, that introduces some interesting challenges to even identify who the patient is, which, you know, we're getting better at. But the other thing is, with the changes in the industry, I think acquisition's another piece that is very similar, that converting people off their systems. One of the interesting things we did at TriHealth was to determine very early on that we were only going to have one electronic medical record, and therefore that's sort of helping with the data quality problem, but still conversions can really introduce some challenges. I'd say that the third thing is really flexibility in the EMR, from the standpoint that, you know, systems such as Epic have multiple places that you can enter in the same data, and therefore as you're starting to look which piece of information to pull, that introduces a challenge. And I would say lastly, and there's way more than this, but just off the top of my head would be the concept of notes. Doctors are very busy people. They struggle with putting out discrete data and therefore are always looking for the option to put in notes. And so that concept of translating a note into discrete data also injects some serious challenges for data quality.
Wow, you covered definitely a lot of things there, and I think let me ask you real quick. Let me follow up with you, Tom. What about you talk about one EMR, but we're never going to get away from ancillary systems, are we? I mean, are
Correct.
there other repositories, right, in the health system where the one EMR is going to help because at least you don't have multiple EMRs, but still you've got all of these little niche applications around?
Well, yes, I think the answer definitely is yes. So there'll be satellites, and obviously as the big EMR vendors try to cover more and more, they'll come out with modules, which, by the way, will introduce conversions, which creates one of the data quality problems. But you're exactly right. I mean, if you look at cancer, for instance, a lot of their systems with precision medicine and stuff require very specialty software to drive, and therefore a lot of the medical record for somebody in that specialty case is housed there, and really the EMR almost becomes just a billing engine at that point. So yeah, that is most definitely there and continues to be a challenge. But you know, I remember the days of having a sick child and going to our local children's hospital, and it almost seemed like every floor had their own EMR, and you were re-registering and so on and so forth. So at least that piece has been corrected. But as we get more specialized in more specialty services, you're dead on that those ancillary services and systems are there.
And just a little bit more, you mentioned something about Epic entering information in different places within the one EMR and having some issues about that. Can you just expand on that a little?
Yeah, I mean, I think out of the box you're going to get a base system that has a set of fields, but as you start customizing workflows and looking at how you're going to care for the patient in specific situations, you can create flow sheets, which really is just a way of customizing the interface. And therefore, not only out of the base Epic system, but out of things that you're doing to try to optimize the workflow for the care management team, you're potentially creating additional ways of entering the same data in different places.
Interesting, and I'm sure it's not unique to one EMR. Probably.
No, and you know, Notes is a very similar example to that, where you know, conceptually you want to have all of a patient's problems, allergies, meds in discrete fields on a list, but a doctor that's in a hurry may very well just sort of write his notes in there and you know, define allergies or meds or diagnoses that they're doing based on that one visit, and it becomes very difficult because that's now written in a non-discrete way. Right. And of course it could be negated, right? So you could say don't have an allergy to something. So, you know, I think all of those things pose a challenge because the human has to enter the data, so you're figuring out which field or which note you're pulling that data from. And that flexibility in its very nature creates the problem.
Chris, your thoughts?
Well, I certainly think that, you know, Tom did a great job of kind of identifying some of those, you know, key reasons that we've got challenges. And certainly what we see is that, you know, as you're starting to, you know, bring together different parts of the healthcare business, as you're starting to treat ambulatory and inpatient care, starting to leverage common systems, you still have, in many ways, and in many organizations, just differences in the way things are defined, the way the business process works. And so often, fundamentally, it's even, you know, as we're talking to peers in the organization, we may not have a common definition for things like, you know, encounter and length of stay, and all of the things that are seemingly common have, you know, different realities of really what that represents within the organization. And so in many ways it even just starts with are we talking about the same thing, being clear in our language, and then ultimately, you know, can we help the organization understand where those differences are and how they play out. because the reality is that we're often making, multiple copies of data. Even if we have consolidated ourselves down to a single point of entry, then the challenge becomes, what's the appropriate version of that information to use for my needs? And so being able to just fundamentally getting everyone on the same page from a definition perspective, and then understanding, all right, what is the appropriate data to support an answer to that question, really are some of the things that we're seeing as fundamental to the governance challenge within healthcare.
Very good. Kirk, do you want to comment at all on the reasons for poor data quality?
Yeah, Tom and Chris both make some great points, some great observations. When you start to work on data quality issues, when your data quality improvement program is really in full gear, it doesn't take long before a couple pretty clear patterns emerge and the root causes. Of course, before you start fixing historical data, you've got to get at whatever the root cause is that's causing the bad data to accumulate. And it almost always traces back to two root causes. One is, I'll call it the lack of a stewardship mentality, a stewardship mindset. And it happens at the point of data creation, so it's the provider who's would rather write a note than put data into a discrete field so that it can be used by analytics downstream, or a rooming nurse who, when she's taking some information from a patient, inappropriately uses a field to explain something when there's maybe a note field or a comment field right next to it. A particular example I'm thinking of is like using a date field that might have some flexibility, like for medical history or surgical history. Oftentimes a patient will give some information about, maybe the last time they got a colonoscopy. You can't quite remember when it was. It was 5 or 6 years ago. And in that date field, the rooming nurse might put something in there like, patient couldn't quite remember, it was 5 or 6 years ago. And the EHR vendor allows that because they know that patients will give kind of an inaccurate version of the date. The other important root cause is, I think it comes back to we don't, across an enterprise, we don't really think about what it takes, level of effort it takes to follow through on the data updating processes that we ask our operation managers or other clinic staff to perform. Certain updating is incentivized. For example, if you're going to add a provider to a department, well, you're going to do that because you want to be able to schedule appointments for that provider. So, as you're onboarding a provider, you're going to go through those steps and get the provider on, into the EHR. But over time, that provider might move to a different department, and there's not quite the same incentive to go in and remove that provider from his association with that department. You're just not going to schedule appointments, and the staff knows not to do that because the provider's not there anymore. But when you look to see, when you're using the data to see what providers are associated with a given department, well, there he is, even though he hasn't been there in a number of years, perhaps.
Right. Right, and you said there's no incentive to take him out, so it just sits there.
Exactly, and so when you're resolving data quality issues, oftentimes, maybe even most of the time, there's a pretty significant process reengineering component to actually fixing a data quality issue, and that quite honestly, that can almost be more challenging than fixing historical data.
Mm-hmm. Mm-hmm. Very good. Very good. Thank you. All right. Next question. Let's start with you, Chris, on this one. Can you give some examples of how poor data collection processes on the front end can result in bad data on the back end?
Sure. Absolutely. Great example of this is, again, just kind of understanding, what do we mean as we're starting with that definition. When I capture my last seen date within a given encounter field, what does that really mean? And is that within the context of my primary provider, any service? Being able to really understand what those things mean in the early part of the problem is certainly where we see a lot of these quality challenges arising. And certainly as we kind of look at how the data starts to move through the organization, being able to understand who's responsible. It's great to know that, okay, this data was really initially captured at registration, but as Kirk indicated, if we identify that there is a problem downstream, who has responsibility for resolution of that, and do we have a culture and a mechanism to address that issue? Or am I, as a user of that data that I've identified as problematic, really responsible for documenting the issue, tracking down who to send that issue to, and do I get the feedback that somebody's doing something with it? Because certainly, most people have a full day's worth of work in front of them as it is, and adding that extra burden, especially if there's not a clear, kind of reward and payoff and culture of improving, can be challenging. So understanding really who has ownership, and we've done a little better job, I think, as an industry of starting to kind of align ownership of domains or systems of data to individuals and departments, but we haven't probably gone to the level of depth to really say, okay, when we've identified that this is a issue that's created on the early phases of the data capture, of really where the data comes into the organization, who's responsible for taking care of that versus, is it a problem with how the data was combined downstream? So being able to understand those responsibilities, I think, is another one of the challenges that we look at as we try to unwind this challenge. And in many ways, we suffer from a little bit of, I think, a lack of understanding and documentation. We've got a lot of flexibility to customize the applications that we're using to optimize for the care delivery process, but we often don't do a good job of understanding that we've used an override on a given data field within a form. We've collected something that probably wasn't intended for, or we've added something to the default configuration. How does that actually flow back, both from a data process and a data flow perspective?
And Chris, is there a process of identifying a particular, down to the individual level? So you have somebody, a clinician or an administrative person who's inputting data for patients, and they're continually doing something wrong or in an incorrect manner in a way that's causing data difficulties downstream. Do you think most health systems have a way of drilling down and getting to the individual level and then educating that person to get that fixed?
Unfortunately, no. I don't. We're not doing a great job of that yet. Certainly, we see organizations that are getting better at that, and because it's an extensive challenge. We're collecting a lot of data across the organization, and it takes time to really understand where each of those pieces of information enter the organization, who's kind of responsible for that process, and what's the relationship between the individual who had hands on a keyboard and captured that information and the domain owner and responsibility. So even within some of our quote well-defined, well-owned clinical data, we still have lots of different people involved in the process around that. And so it's making sure that for the priority data elements, you've done the work, you've done the diligence to continually refine and increase the specificity. So it's not enough to just know it's registration's responsibility. You need to understand, okay, we've got 3 different registration entry points, and within those, how are the different groups going, which really ties back to a core concept, which you can't improve what you're not measuring. So
right.
if you're not starting to measure some of those things, it's really tough to make those improvements.
Tom, I'm thinking of an assembly line just came into my mind, and the idea that you want to catch the error as soon as possible. So if the error is made early on the assembly line, you need people overseeing the process that grab that piece and say, that's bad, put it back. Oh, the person that did that, you need to go back for some more education because you put that piece on wrong. And if we're not doing that, then by the time we're spitting out reports at the end of the assembly line, those reports are flawed.
Yeah, and I give you another example, and this will sort of combine a little bit about what Chris and Kirk have both talked about, which is, all of us in this transformation in healthcare are looking for how we grow our customer population as we move from a fee-for-service to value-based. And, one of the critical things that Kirk was talking about is getting a doctor into the system so that his patients come into the system and that we're actually serving those patients. And, the challenge is a lot of us, we have employed physicians as well as a physician hospital organization, which are two different administrations. So as doctors are coming in, whether they're affiliated or employed, there's a separate workflow that enters those doctors in. You got to figure out what they're credentialed for. Then you got to figure out which offices they're working out of and what their schedules are going to be and so on and so forth. So with these discrete workflows, you can run into some serious challenges because, by the way, those things aren't all managed within a singular system either. And now you start thinking about what the end impact of that data quality, if we don't get it in there right, the proverbial patient that's looking for a new doctor to deal with some symptom that they're having, whether it's through a Google search or on your website, may not find the right doctor or may get an appointment with a doctor that the data quality is wrong and they don't actually service that. An example could be your best cardiologist could pop up for serving vertigo. And it's probably the last appointment that you actually want a patient to make with a cardiologist that's doing surgeries primarily when they really are suffering from vertigo, but the whole dizziness thing can be related there. So I think, to all of this, it really gets to how does the process clearly get defined and streamlined, to use your analogy of an assembly line that is well-tuned and puts out quality information. And, part of this is how do we combine that feedback loop where we can start seeing searches or patient satisfaction things due to poor appointment matching and so on and so forth to inform the process and almost get into a lean concept of improving the process as we iterate through.
Very good. Kirk, do you want to, any comments on that?
I think there's, going back to a couple of those examples that I mentioned earlier. The data point, making sure that the data is correct in the source system seems to be, a really important key. It's tempting. We have tools that we can use to do transformations on the data so that, by the time they're getting into the reports, some of the data cleansing, some of the standardization has been done. But if you take that approach, there's really not an end to it. It's an important idea to create that stewardship mentality. Everybody is a data steward. You hear that thrown around every once in a while. Everybody is a data steward, and to take that extra few moments to think about what you're putting into the into that data holding system, and where you're putting it, so that you're so you're maintaining the quality of the data as high as possible in the source system. That seems to be a really important key.
All right, very good. We're going to go with our poll here. I'm going to open the poll now. And if you want to take a second, answer that when we discuss the results. How would you rate your organization's front-end data capture quality. So are people doing a good job capturing that data on the front end, or are there a lot of problems coming in at that point? So answer that question if you would. We'd appreciate it, and we will come back to that in a moment. Next question, Kirk, if we could stick with you on this. What is IT's role in ensuring data is being collected in a consistent and thorough manner? So talk about IT's role versus the roles other departments may have and how you work together with those departments or lead or follow, that type of thing.
Well, one of the most important things that IT can do is, going back to what I was talking about a moment ago, they can resist the temptation to use ETL processes to do the remediation of data that wasn't input correctly in the first place. Most ETL tools have the ability to do a transformation to change an incorrectly to change an incorrect description to some sort of standardized description, but you want that to happen when the data is actually input, instead of relying on your IT resources to undo the errors that are made by the folks who are creating the data, but doing so in kind of a careless way.
Tom?
Yeah, I would echo that. It even gets worse as you start talking to people about more advanced things like data lakes, where now the transformation actually goes up into a reporting vehicle on the way out of the data lake versus the ETL on the way in. So I think to echo to that, as these things are ultimately being managed by IT, I also find that we oftentimes are weak on thinking through the testing and automation of the testing to validate the data before it gets ingested. We're too quick to go in and just do the transformation and fix it versus alerting people. And I think part of this really gets to the data quality, to Kirk's point, needs to be fixed in the source system, and it needs to be a partnership. So I think one of the bigger challenges has little to do with technology as much as it does IT needs to make sure that that stewardship mindset is understood with the partner on the business or clinical side engaged within the effort that maybe is using that data to make sure that we're really thinking about where to fix it, which is, to Kirk's point, in the source system. And, just as an example, and this is not a healthcare example, it can go anywhere. If you sort of look at state codes and you sort of say, I serve different areas or zip codes, at times you look at how much it would cost to write an ETL process to update the source system with the right information or the target versus somebody just sitting down and putting in the right data. And there's a cost equation to come into play. So we'll expend tons of money to fix a problem that, quite honestly, a user might be able to fix in an hour or less and be a lot more economical for the system.
Very good. Very good. All right, let's look at our poll results here. And we see, it should be shared with you, 17% think their performance is above average, 50% average, and 22% below average. Chris, any thoughts on those results?
Not terribly surprising. I think I certainly love the concept to understand, is average good enough? And certainly I think I would make the statement, and hopefully most folks participating would agree that we need to do better than average. It's not enough to say that, yeah, we're doing okay at this. It really needs to, we need to think about, how do we move ourselves forward in that, and overall as an industry, provide that additional visibility and responsibility so that we can improve.
Yeah, and I would agree with you. So taking it from that point of view, we have 77% think they could definitely improve. So there's some work to be done out there. Tom, let's go with you on this one. What is the role of data governance in ensuring quality data collection processes are followed, and what is IT's role in establishing and enforcing good data governance?
I think every question's like a loaded question. So, you know, to
That's
me,
right.
I think there's multiple facets of there's multiple facets of data governance, right? You could look at it at a very low level within the database, or you could really look at it semantically. So when I look at this, I feel like data governance is really how we get everybody to a level of consensus around the key data that we're leveraging within the system. And, you know, the process really, in my opinion, needs to be owned and likely owned by the business or clinical areas, because we've got to get people to start realizing that the data that we're capturing within the systems really is an asset that, if it's properly managed and has the right quality, can really be transformative to help our business move forward. I think at times, if IT takes too much of the lead, it tends to just be another initiative from IT, and it doesn't get that consensus and buy-in from all parties. So from my standpoint, I think those are probably the key pieces, and then there's the stratification of saying, A, what does the information mean semantically, whatever we want to call that. There's also the lower level, how quality is the data. But I think one of the things that may be a little bit unique to healthcare, although financial services probably has it as well, is some assets can put you in jail. So if we start putting analytical sets on top of patients and somebody just goes click, click and gets a whole list of patients and so happens to print that and walk out the door, we've just had a data breach that could be very challenging. So when we really think about this, it's not just about defining it or what the quality is, it's really about wrapping that with the policies and procedures and rules to say who can touch what. And all of that becomes a guidebook for making sure that we steward the information properly across the enterprise.
Very good. Kirk, thoughts?
Yeah. So when you think about kind of the ultimate role for data governance, you know, a number of things come to mind, but at the end of the day, if you wanted to put the purpose of data governance on a bumper sticker, it would be something like to get the most value out of the data that you possibly can. And so, you know, you can work really hard on your data quality program. You can you know, find all those critical data elements and you know, develop all sorts of strategies to monitor the quality of those data elements. But you know, you're not really getting the value from that data until everybody's actually using that data everybody who could be using the data to improve the you know, to improve the work that they're doing in their particular part of the organization, and they have they're using the tools properly, and you know, they're thinking through you know, different innovative ways to improve their operations. You know, in a word, that's called data literacy. And until you have that, you know, kind of data literacy as almost as a core competency in an organization like a healthcare organization, it's really hard to you know, to get folks to take that extra moment to you know, to make sure that, you know, that the data that they're creating, that they're doing it just right. And I don't know of any other part of the organization that is in a better position to champion that idea of data literacy than the data governance function within an organization. We actually spent a lot of time on it. You know, we talked about the stewardship mindset. I would offer that that's really just a component of that whole idea of data literacy, and the tremendous value that it can bring to an enterprise.
And Kirk, what you're really talking about is making people care enough to be accurate and put things in the way they're supposed to be. Is that right? Yeah, exactly. And I mean, said another way, you want to make sure that they understand that they have skin in the game, right? Yeah. That if the data that they're creating is of, you know, suboptimal quality, they're not going to get the value out of it on the other end. The analytics that they're relying on to do their jobs better and better, to care for patients better, to get better outcomes, or, you know, let's face it, generate more revenue, it's compromised. All right, very good. All right, Chris, let's go with you on this one. You've worked in a lot of health systems, you know, bringing your products, talking to people, investigating what their needs are. So what do you see as some of the common problems out there around data governance?
So I think what we're seeing as really driving, I think, an expanded interest and focus on governance is that, you know, we've accepted kind of the fundamental shift as an industry that, you know, using data to drive our decision process is important, but what we're finding is that people really don't understand the data that they're being asked to use. It's about that data literacy. So they don't have kind of the context to be able to make the right decisions. So often we'll see that the analyst who's creating a report, who has created a report, and the consumer of that reporting asset don't even speak the same language about what the concepts that the report represents. And so you've got to kind of start at that level to be able to, you know, does this mean what, you know, it was intended to mean as we created that analytic or that report? And then there are additional questions that are really needed to be able to reach that level of data literacy. You know, most of the organizations that we work with have a handful of folks who have been around the organization for, you know, typically 10, 15, 20 plus years, who have just been the hands-on people in the data consistently. And you know, for a while that was sufficient. We could go to Sally or Jane or Jeff, whoever that expert was, who really kind of knew the data, and they would act as that you know, translator between, you know, what do I mean and, you know, how we represent things technically within the organization. But as we've kind of made the shift to become much more data-driven, the requirements for who needs access to that information has changed radically. So we've got a lot more people who are demanding, you know, Sally, Jane, Jeff's time, and we can't scale those organizations. We can't scale those people. We've got to get everybody at least partway down the journey that it's taken 10 or 15 years to get our data experts and our go-to resources, get them to that point. So we've got to start to say, how do we scale that as an organization? And I think a lot of what governance is doing is formalizing the tribal knowledge that organizations have put together. And then we've got to do that in a context where it makes sense to people see the incremental investment. And so we're seeing a big shift for organizations really starting to tackle that challenge of, you know, how do you make sure you find the right data, and kind of starting with that point in the process, because the reality is that we've got a lot of opportunity to leverage the data we're using, and there's energy and excitement to invest and engage in governance efforts. But as you know, there's got to be some return, or people get pulled away to other things. And so starting to answer that question, you know, how do I quickly find the information that's available, and how do I raise the organization's level of data competency and data understanding are things that we're seeing as the driving factors within a lot of governance organizations as they're starting to pull together and coalesce around a mission.
Excellent. Thank you for that, Chris. All right, Kirk, let's go with you on this one. How can hospitals do a better job of collecting data in a consistent way?
Well, you know, I think once it's kind of a cycle, an iterative cycle. The first thing you have to do is help the members of the organization, the clinicians, the clinical staff, administrators, operations folks. You have to help them understand that there really is tangible value available from the data. Analytics that, you know, you have to produce a few analytics that can, quote, you know, move the needle for some of the different parts of the organization. And then once they start to understand that the analytics are truly helpful, that they're helping the organization achieve its goals, Then the next step there is to help them understand how the work that goes on, the work that they do contributes to the quality of the analytics that are helping them do their jobs better on behalf of patients and the rest of the organization. I think that's it's the practical approach to building the data literacy that we're talking about right now.
Very good. All right, I want to move through some questions here as we have about 10 minutes left. So, Tom, let me go with you on this one. Is there a way to remedy poor data collection further downstream, but before reports are produced? Is there a point at which bad data can be cleansed or normalized? So bad data comes in, how do we catch it? When do we catch it before the report comes out that a clinician theoretically is going to take some action based upon?
I think the answer is definitely yes. There's always opportunities. I'll echo Kirk's statements on this, where I think you really want to get it remedied in the sourcing system, but as we move downstream, obviously ETL tools and things of that nature can help fix it. I always look at this and say, if you think of a dashboard report, a scorecard as sort of the end state of the data, the source would be the best place, and you want to get as close to the source as you can. So, for instance, things that we've been working on, even on provider, since provider is sort of split amongst the EMR and credentialing system and things of that nature, is how do you start building sort of transitional master data before you ultimately move it into something like a data warehouse that can be used almost as data-driven cleansing, where you really get, there's not a single source of the truth for the whole data set. There's multiple systems that are providing some piece of the truth. So how do you get that, stage it up, and actually have the ability to map it to other systems that can then flow it through to the other systems? I think the worst thing you can do is to do it in that reporting environment. So if you're in a Tableau or a Crystal or a Business Objects or something of that nature, if you're putting in transformational rules up in the reporting tool itself, that's probably the worst case. So I think the main thing you want to try to do is keep working back closer and closer to the system, because the ultimate would be to do it in the source. Chris, your thoughts?
And certainly I think we would agree. And without question, the closer you can get to that source system, the better. But in many cases, there are, perfectly valid and reasonable constraints. You've got data often coming from multiple sources, even as you're moving towards that single EMR, and we're seeing more data from outside the system, roll into our analytics process as we're doing comparisons, benchmarking, other, data sources coming in from our ACO groups and other attributes that are really kind of expanding the walls of the organization. So I think we'll continue to see that, data quality process, gets implemented in multiple places. I think the key is to make sure that the consumer of the information really understands, what has been done and where, so that they can, as part of their use and consumption of that, really validate, is that appropriate for my needs? So providing that picture to say, hey, we've done some remediation, that's important. And even before that, just as an organization, be able to understand your data flow environment. So, what data is feeding into this analytic or this metric that I'm working with, and what are the potential points where some work has been done to coalesce or massage this data together, and does that still fit my needs?
Very good. All right, Kirk, let's go with you on this. How can IT give clinicians confidence that their reports being produced about their performance are accurate? And we know this is always more of a challenge when they don't like the results of the report and what it says about how they're performing.
Yeah, that is definitely true. Well, there has to be some very visible way for the clinicians or any consumer of an analytic to identify a report where the controls are in place to monitor and detect any time the quality of the underlying data, the critical data elements that are used to that are supplying the different metrics on an analytic. Anytime those critical data elements are beginning to slip below some established threshold for quality, it's a pretty extensive process to do this kind of work, but it pays off great dividends. You aren't going to do it probably for every single report you've got. I mean, maybe 80% of your crystal reports are kind of, I'm not going to say they're not meaningful, but they have less of a strategic impact on the organization. You'll have 20% of your analytics, let's say, that are being viewed by your executive leadership or maybe your service line leadership, and important decisions, important business processes are dependent on the accuracy of those. For those analytics, it makes a lot of sense to do the work to establish monitoring on the critical data elements that in the source systems that eventually flow into those metrics. And then once you do that, then in some sort of a very visible way, you want to display the fact that you're monitoring the quality of the source data elements and are sure that the quality is above that pre-established threshold. You hear talk about watermarking or some sort of an indicator like that right on the analytics, so that right next to the number that somebody may have doubts about, there's this indicator that says, and all of the data that underlies this analytic has been checked and it's good.
Very good, very good. All right, I want to throw, a few minutes left, I want to throw a question out at you gentlemen, and we'll start with Tom on this. So, as I've listened to our conversation, we're talking about the importance of data. We like clicks. People who want quality data need clicks, right? Clicks are good for data. It means we're getting discrete data, and that makes us happy. Physicians don't particularly like clicks, right? I read an article this morning or yesterday about physician burnout, and they attribute a lot of it to the EMR, and everybody cites the number of clicks it may take to do any particular thing, like ordering a flu shot. I think it was 20-something clicks, or it might have been 30. So we have this issue. We have the need for good data. The future is data, being able to understand what's happening with our patients, versus this other need and this desire to have more of a narrative and less discrete data and less clicking. So how do we merge those two things? How do data professionals like yourselves and those on the line get what they need while not making the practice of medicine, I guess, so unpleasant people don't want to do it? So Tom, let's start with you.
Yeah, I think we probably all have a number of initiatives that are trying to focus on this. I mean, I think the one benefit that's starting to happen in the industry is the onset of a more technically savvy consumer. But, you still get the questions from a clinical side whether that, information that you're going to get from them is right or not. So, a lot of automation aspects, you look at registries and kiosks and things of that nature where the patient can actually provide some information from themselves in. I think we have initiatives going on with natural language processing, which appears to have a pretty good promise for pulling things out of unstructured or semi-structured notes and at least being able to place some of the more critical things like problems and allergies and meds and diagnoses into a form that can be used. But, I think more than that, there's this engagement that has traditionally happened. There's almost been like a wall between the user, whether that's a clinician, doctor, finance person, and the IT people, and things just get slung over the wall to each other. I think part of this is that human aspect of engaging people really starting to get them to become literate with what the information's doing. I like to look at it and say every time we're going to implement some sort of feature or module to help them, that we don't think about the reporting or data as an afterthought, that we think of it in line with that module, so as we're working through that implementation or rollout, that people can actually get that visibility as to what their actions do to the information. So I think it's really raising that intelligence and getting people engaged in that becomes the more meaningful aspect to help people understand that. Once they do that, I think you can really get to the point that the data capture system can be cleanly streamlined and the options and flexibility start getting reduced, you know, as we go forward.
Very good. Kirk?
Well, we're dabbling in natural language processing as well, and it does show some promise. I'd be reluctant to suggest that it's going to replace the importance of discrete data, but it's definitely a help. Boy, I definitely have to echo Tom. You know, that the things that we on the data side, the technical side, think that we're doing to enable the providers, a lot of times it's not as enabling as we think.
Well said.
And you know, we can't spend enough time up front working with them and you know, kind of cultivating relationships with them, so that we really understand what they're up against, and that we design, you know, around some of those very challenging, you know, facts of life that they have to deal with. One important initiative that we have pursued here at Geisinger is what we call the physician informatician. We almost don't make any move, you know, when it comes to you know, some sort of customization of the EHR or you know, really any initiative that's gonna have an impact on the way our providers are delivering care to our patients. We don't make a move without involving these physician informaticians and letting them advise us in the early stages of the, you know, while the idea is still a twinkle in our eye. And then as the idea gets closer and closer to fruition, those physician informaticians are essentially our ambassadors to the providers that we're, you know, that we hope we're helping to you know, to smooth off some of those rough edges, so that adoption goes well, that there aren't as many, you know, painful lessons that have to be learned after go live, which is certainly a problem that we've dealt with in the past.
Very good. Chris, we'll give you the last word.
I think that you know, both Tom and Kirk touched on, you know, a key concept, and it's about that shift in culture and making sure that people understand why we're asking these things of them. If we do ask, you know, for them to add additional discrete data, that, you know, there's a clear understanding of why and what the organizational process is. And so there's always a tension and a trade-off through this process, and certainly I think, you know, kind of in our current state, physicians have dealt or been dealt a lot of the burden from this process. Clinicians that are, you know, at the really the nexus, the point of care, that have a lot of demands on them already. And that's the reason I think it's important to, you know, certainly as Geisinger is doing with their physician informaticists, being able to bring the right stakeholders together, so that it's not a top-down edict. It's not just an IT, hey, we need this. It's not just a management dictate. There's a collaboration between, all right, well, you know, if we do ask, you know, for this additional discrete information, what does that mean from, you know, the patient experience, and are we in agreement that that makes sense. And so bringing together really a multi-stakeholder group, which is often one of the things that governance gets a little bit of a black eye for, and really being able to facilitate an honest, frank conversation that fits the goals of the organization, I think is the fundamental step. And being able to not only have those conversations, but document why you reach that conclusion and what the benefits and trade-offs are the enablers that hopefully help the organization shift away from, and consider how, data as a new asset really impacts the organization culture. There's rarely anything for free, and so making sure that we've taken the appropriate accounting of impact, I think, is important throughout this process. And it takes a multi-stakeholder view. The problem is too complex for, IT, for clinicians, for anyone to have really the full picture. So we've got to collaborate and work with our colleagues, make that easy as possible.
Excellent. Thank you, Chris. All right, well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could answer that, we'd appreciate it. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our webinars, so let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive recording of today's event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of webinars. I want to thank our panel, Chris Hanson, Tom Hammergren, and Chris Cooper. I want to very much thank Collibra for making today's event possible, and I want to thank you, our attendees, for attending our events. With that, everybody have a wonderful day. Thank you.